We will get started with the talk topic session now. The talk, it is tough, is a short, innovative talk to inspire broader thinking, and today we have Professor Stephen Hoffman joining us. Professor Hoffman is the director of the Global Strategy Lab, a professor of global health, law, and political science at York University, and a scientific director of the Canadian Institutes of Health Research Institute of Population and Public Health. He's also professor of clinical epidemiology and biostatistics part-time at McMaster University, and the adjunct professor of global health and population at Harvard University. And because he wasn't busy enough for 2018 and 19 academic year, a visiting professor at the University of Oxford. He is an international lawyer licensed in both Ontario and New York and specializes in global health law, global governance, and institutional design. His research integrates analytical, empirical, and big data approaches to craft global regulatory strategies that better address transnational health threats, social inequities, and human rights challenges. This morning, Professor Hoffman will be speaking about how artificial intelligence can impact public health and health equity. A short Q&A session will follow Professor Hoffman's presentation. So please, welcome Professor Stephen Hoffman to the stage.
First, a big thank you for the invitation to be here. It's really quite an honor. I'm going to start this talk today with a fact, which is that your job, as it now exists, will not exist in 20 years. The good news, your job's still going to be there. You're all going to be employed. Public health is one of the most exciting fields in which we're seeing increasing needs, and as time goes on, there's only ever more need for what we do in this room. But the tools and the approaches, the strategies we take are changing. Now, this isn't totally new for us, right? We're in a field we've always changed. I mean, we have been part of change over time. I mean, think back to public health before 1853, before we had field epidemiology, before John Snow did tracing to figure out that it was the Broad Street pump that was spreading cholera in Soho in London. Right? We invented epidemiology. We've used it, and it's one of our most important tools that you use on a daily basis in your practice. We invented cohort studies. Think back to 1948 when the Framingham Heart Study first existed. We've learned so much from cohorts. So much about how a variety of factors influence our health and then how to intervene in order to make and encourage and help people be as healthy as they can be. Today, still, cohorts are leading some of the most interesting insights, and there's several in Canada that are really doing some fantastic work, and of which all of us can be very proud. More recently, thinking not of a methodological approach, but a conceptual framework, the social determinants of health. Thinking in that way, I think, has also revolutionized public health and allowed us to really understand that so much, the vast majority of our health, is not determined by our ability to, or visits to in the healthcare system, but actually the broader structural environments in which we live, whether that's a social environment, economic, cultural, political environment, which would then also include access to healthcare, but that's only one part of it. That framework has given us a way to think, and we've fully adopted it within public health, such that many of you are probably thinking about the social determinants every day in your daily practice. My worry, though, is that are we ready for the next types of changes that are coming? The world is changing, technologies are changing, and are we as a community ready to take full advantage of these new technologies in order to further what we can do to contribute to people's lives? The three examples I gave earlier were all examples where it was actually us within public health who were the innovators. We were the ones who came up with these new approaches, we applied them, we scaled them, and we, through them, have made a difference in people's lives around the world. My worry is that one of the biggest changes coming up that are right ahead of us is something that's not from within our field, it's something we're gonna have to respond to, take advantage of, make sure it's going well. In other words, I see we have a data iceberg ahead of us. It's not our creation, but time is going and we're being pushed towards that iceberg. And the interesting thing about icebergs is that it can go two ways. One is we can crash right into it, and then we can think about the Titanic and what happens from there. We don't want that. We've all seen that movie. It doesn't end well. But the other interesting thing about icebergs, or the other way of thinking about them, is that people actually find them beautiful, and they are. If you have ever been to Newfoundland, to the northern part of the province, to go iceberg watching, it's incredible. If you haven't had the opportunity to do that, I would try to make it out there. You actually go, you spend hours driving up to one of the towns to hop on a boat, and you're trying to actually seek out icebergs. They're beautiful. It's really quite majestic watching them float along. This can be great. Big data and the opportunities that we have to analyze it and inform what we do in public health are enormous. But we need to make sure that we don't crash into the opportunity. We have to steer the course. We have to proactively figure out how to take most of it and actually reap the beauty that it can offer. A slightly darker way of thinking about it is that I'm worried that we're actually unprepared for this future that's crashing into us, like it or not. And my worry is that even if we don't take advantage of this opportunity, which would be an opportunity lost, my worry is that if we don't, it doesn't matter because others will. And sometimes others, when they take advantage of these technologies, it's great. We all have applications of artificial intelligence already that we love, and that's great. My worry is there's quite a few actors out there who are not necessarily acting in the public health interest. In fact, there's some who are selling products, for example, in the unhealthy commodities industries, whose very purpose is to sell things that is against what we're trying to promote. Tobacco, cannabis, alcohol, right? Unhealthy foods. They are already using these tools. They're already using them, and my worry is that to the extent that there's a little bit of a tug of war going on, they're bringing a big sword, or they're bringing the big guns of big data, we're bringing a butter knife. If we don't act, we'll be bringing the butter knife when we don't have to do that. Let me give a specific example to walk through what I mean. Imagine all of the data that's posted on social media right now. Tons of information. Just by way of hands, who here has an account on Facebook? Okay, everyone. Everyone here has an account on Facebook, lots of information posted. If I was a tobacco company, theoretically, that would never happen. If I was a tobacco company, where would I try to search for my next customer? On one hand, I could try to find somebody who's already smoking. I don't have to worry about them. They're already addicted. They're smokers, and they're already there, going to buy my product. I want to find somebody who's at greatest risk to start smoking. And who would that be? Well, research shows one of the top predictors of whether someone starts smoking is whether their friends have just started smoking. So you can imagine if you have an ability to find out whether someone has just started smoking, you don't have to worry about them. You want to know who their friends are. And Facebook and other social media platforms would theoretically allow that to happen. So let's walk through an example of how that would look. So let's take a random Facebook profile that we can see on Facebook. So this guy named Mark. Looks like a cool guy. And what's interesting is Mark has posted quite a lot of information about himself on Facebook. So we know what company he works at. We know his wife, Priscilla. We know where he grew up. We know where he currently lives. We also know who his friends are. Now, I'm proud to say I have more friends than Mark, but But what's interesting, if you look at the top 6 in this random person's website, or Facebook account, of the 6 that are just showing there, you'll see, maybe take a closer look, and there's maybe a couple there that might stand out. We have a couple of smokers among his friends. Now, I assure you, whoever Mark is, he's not looking at his friends' pictures on a daily basis. But AI can, algorithms can. And so what we actually then not only know that Mark has friends who are smokers, we actually, AI can know when they started smoking, when they started posting photos for which, using deep learning or other mechanisms, they could actually, through computers, be able to identify who's a smoker based on what photos they're posting, or based on what texts they do, or based on what tweets they post. And so if we were a tobacco company, which again, no one here would be, but if we were, we would be looking to use AI, trolling these things in a way that we as humans could never do. Imagine a system where we scrolled everyone in your jurisdiction, we scroll to try to find out who has friends who are smoking. Impossible, right? We don't even try. But with the computer algorithm, it can do it automatically, and people can act on it. Now, that's a bit dark. There's also a flip side. So yes, that's already theoretically possible, if not already happening. But we can do the same. Because based on the exact same information, all of which is publicly available, we too can do that and act appropriately. What tobacco companies might call a future customer, we might call someone who's in a vulnerable state, at risk. And they don't even know it, because Facebook knows when they're at risk before the person does themselves. And so what we can do is we can make sure that when Mark is looking on his Facebook page, for example, instead of only seeing Ferris wheels that his friends have posted, he can also maybe see an ad that says smoking causes cancer, and we can reach out to people. Now, I'm not promoting the idea of paying Facebook money to have ads and such, but I am highlighting that the same techniques that certain companies can use for their next customers, we can use to support people who are at risk in reaching them. And even if we don't take advantage of these technologies, others will. And so that's where the butter knife and the sword comes in. So AI is not new. It's just a method. It's just a collection of approaches. It's been around for a while. But it's more powerful now than ever before. And that's for at least a couple of reasons. The first is just the sheer quantity of data. As that slide on the iceberg showed, we are generating as much data every 2 days as we did from the beginning of human history until 2003. So these 2 days that you're here at this conference, we are generating around the world as much data as from the human history till 2003. That's powerful. The second is that we now have computers that are more powerful than ever before, allowing us to analyze and interpret this data on a scale that we couldn't earlier. And so just by way of analogy, when my parents were at the University of Toronto, they were building a supercomputer that would have been the size of this room. And what we called a supercomputer back then could be far outperformed by the smartphones that the 1,000 people in this room have, each one individually. So back in the day, a computer would have fit in the room. Today, we have at least 1,000 supercomputers, and each one fits into your pocket. That's powerful. And increasingly, we're able to make use of that power in order to sift through this gigantic pool or iceberg of data that's ahead of us. So I've been talking about AI, and I've been trying to flag that this is something that's new but not new. It's an opportunity, but if we don't act, also a risk. Let me just very briefly try to demystify for a second what actually is artificial intelligence. Because as was mentioned at the beginning, I'm actually a lawyer by background, so I'm not an AI researcher, but I'm excited by this, and I think you should be too. And I think that at its core, AI is not just the math and maybe the nerdy things we see on TV. This is one of the most exciting areas, I think, of research right now, and one that bodes for important things in the future. But ultimately, at its core, it's just a collection of techniques that are used to approximate human reasoning using machines, currently mostly computers. So it's just a method. Now, there's several different methods within it, and so to give a sense, let me walk through just a few of them. I'll walk through the big four, let's call it that way. So the first is machine learning. If there's one type of artificial intelligence that you might want to remember beyond today, beyond hearing this, it's machine learning. And the reason for that is this is the kind of artificial intelligence approach. That is why you're reading about AI so much in the news. It's because this is the approach where we've been able to learn how to make predictions, so computer models making predictions that most closely match observed data and actually continuously improve that learning as more observed data is collected. What that means is that basically this creates a process that can, as new data is emerging through, for example, administrative processes or as through biosensors or in any other way, these models get better and better over time, and as a result, more and more predictive and more helpful. Let's take an example of Google Maps. So 10 years ago, before Google Maps, if you wanted to know how long it would take to drive here to get to this conference venue, you'd go online and you would maybe look at, let's say, mapquest.com, and you would type in and you'd get how many kilometers you're driving, and you'd get an approximate time. The way it would used to work is that they would look at, okay, they knew what streets, and they could map out how many kilometers it was, so they knew the distance. And they also knew, based on city bylaws and such, and provincial rules, what the speed limits were as you were going along. They might have even known where traffic lights were and where stop signs were, because that's all centrally planned and can be incorporated. But it's just a guess after that, right? I mean, traffic changes throughout the day, and maybe they would have put, okay, at certain times of day, let's say 3 p.m., really busy, or 8:30 a.m., busier times, so let's say people are going half the speed limit. It was a total guesswork. And so there's a good chance if you were relying on that number and coming to this conference, you might have been late, and you might have missed this presentation. Today, Google Maps, what they do and what other products do is they not only are providing a guess or an estimate based on what information is available, like stop signs and traffic lights and such, they're also doing it based on the millions and millions of data points and people that have done it before and gone in that way. And every time you use Google Maps, you're actually helping Google to refine its algorithms. Because, so for example, today when I came, Google Maps told me it was going to be 15 minutes to come here to this venue. But Google Maps, it was pretty accurate, and in the sense that I got here in just over 15 minutes, but it didn't know that I got stuck behind a garbage truck. But now there's a certain risk of getting stuck behind something, right? Especially in different places. Google knows where I got stuck. It was because it's a one-way street, it's narrow, you can't go around it. Google now knows that and is able to refine it so that when I go home afterwards, I'll have theoretically, there'd be a better algorithm in order to inform a more accurate estimate. Imagine millions and millions of times coming through. That gives a lot of information to give a better estimate. That's how machine learning works. The second one that I'll flag or talk about is natural language processing. And for this one, instead of me explaining it, let's ask Siri. Hey Siri, what's natural language processing?
Natural language processing is a subfield of computer science, information engineering, and artificial intelligence concerned with the interactions between computers and human languages. In particular, how to program computers to process and analyze large amounts of natural language data. Would you like to hear more?
That's great, thank you.
Challenges in natural language.
Work to be done. Now, Siri got the answer right. She's pretty smart. But her monotonous tone didn't really make it as clear as I'd like, so to make it a bit clearer, natural language processing is the kind of artificial intelligence that allows computers to interpret written and spoken human languages, generate responses to that, and learn new concepts from interactions along the way. It's natural language processing that allowed Siri to understand my question and then to generate a response based on her understanding of the question. And sometimes Siri gets it wrong. And sometimes Apple, in this case, even gets some feedback from Siri. Like, wrong question, right? I don't know if who here talks to Siri? Sometimes they get feedback. And actually, that can then suddenly have multiple types of AI working together. But Siri is one example. But another example that might be really pressing on people's minds today is that if, for example, we were looking to analyze social media data like tweets, we could actually assess whether people are vaccine hesitant or vaccine accepting or anti-vaxxers based on the tweets that they share, right? So already, that kind of AI would be natural language processing. The third type of AI that I'll mention is on knowledge representation. It's called knowledge representation. And this is a type of AI where we categorize concepts, which are then defined and encoded so that human knowledge can be read by a machine. Let's think about IBM's Watson computer, right? The supercomputer that wins chess games and Jeopardy. Now, the reason IBM Watson is so good is because it's largely using knowledge representation. Because basically what it's saying is it's identifying certain features, or once it has a little bit of information, it's able to draw connections between that little bit of information with other things. So in a health context, let's think of symptoms. So if we told IBM Watson what symptoms we have, IBM Watson would be able to look to the International Classification of Diseases, it'd be able to look to medical textbooks and such, and be able to say, oh, that symptom could mean that. That symptom could mean that, and lots of different connections it could draw to actually quite accurately predict what someone might have presenting with those symptoms, or at least a range of things and a certain level of confidence that IBM Watson's computer, that Dr. Watson has. In fact, talking about Dr. Watson, who here, if you had a choice between visiting Dr. Watson for a health challenge that you're facing, or your own family doctor, who would choose their family doctor today? Okay, so about half of the room. The other half would choose Dr. Watson. Interesting. But it shows there's a lot that Watson will know using knowledge representation. And really, it's piggybacking on some existing work that our librarian heroes and the information scientists have been doing to generate these kind of ontologies and connections. And computers are then able to piggyback on that and see the connections from there. The fourth and final example of artificial intelligence approach that I'll just mention today is it's called automated reasoning. And this is when a computer would use known constraints to help both identify and then actually assess different options that are available for decision, depending on the particular context and the data that's available. This is kind of like an AI decision tree. So it would be something, let's take a pandemic context. We would imagine that when the next pandemic happens, because it inevitably will, that we would want a response that's based on the best available evidence. There's lots of evidence out there. How do we access it? How do we integrate it? Making sure that we're up to date on everything. Now, it's not just the evidence, though. Of course, we want to adapt it to a local context. But you could imagine, theoretically, for those who are leading those efforts in the audience, you could imagine that, okay, given evidence, we could actually, in advance, think about some of the constraints that we would want to impose on a computer model and some of the preferences, as well as some of the unique things where maybe we want to make a decision later on. And so we could actually, so in addition to coming up with a pandemic preparedness plan, which might be in a PDF on a computer, which hopefully people can find when an outbreak happens, you could also simultaneously be developing a computer model that could actually learn in real time as other parts of the country or the world are responding, as news media is coming in faster than you can read it, as new evidence emerges in the middle of an outbreak. And you could actually, in advance, use that pandemic planning exercise to think through, okay, if this happens, what should happen? Or if this happens, what are the preferences given the very local context in which you're responsible for leading? That would be automated reasoning. And what it would do is it would allow that if an outbreak happens, you'd have an assisted decision-making device, whereby it would present what are the options based on those former considerations that were thought of during peacetime, and here they are now during wartime, during the pandemic. I hope that gave a sense that AI can help us solve public health problems. And actually, not just solve public health problems, but also think about existing solutions in new ways. To get really even more public health, let me present 3 options that kind of bring some of these different ones together that I think are quite exciting, all of which are studies that have been published in the last 2 years. This one, the first one, is there was a study published that was able to map obesity rates among adults simply using satellite images. It's crazy. Basically, what they were able to do is, if you'll see on the left, they were able to take satellite images, which were free and open access, so available to all of us. And what they did is they applied a deep learning method known as a convolutional neural network. It's a type of, it's a type of machine learning. And what they were able to do is hone in on that image and actually slice it into various layers. That's what the deep learning means. It's going and analyzing something in its layers. And so the first layer was, okay, the model is distinguishing between what's water and what's a building in the satellite image. The next, it was like, okay, we now know what the building is, what's green space? Okay, we now know what green space is, what are the roads? And this study did that 7 times, so created 7 layers. And then what it did is it correlated those features of the built environment and the natural environment that were observable from a satellite with known obesity rates from the CDC in 6 US cities. So it's basically it was creating a model identifying the relationship between those built and natural environmental features identified in a satellite through deep learning, correlating it with known obesity rates, and then it applied it to 150 other US cities. And in the end, what you'll see here is these are maps. So one is a map of Seattle, the other one of Los Angeles, comparing a map with the CDC data, the data that's known based on rigorous epidemiologic methods, and the map that was generated simply from data that was taken from that satellite image. And I know that it's small, but even if you looked up close, you can't really tell the difference. So if you were in one of those 150 cities and you didn't have CDC data, based on a satellite image, public health professionals would be able to estimate at a very small neighborhood level what the adult obesity prevalence is. That's crazy. That's very exciting. And when they did this, it was a part of a study that was a validation exercise, seeing, okay, how well did the computer predict? And actually very well, extremely well. But the surprising thing from this study was they were shocked at how much of the variation between neighborhoods was explained simply by the physical and natural features that were extracted from the satellite data. It was 2/3 of that variation was explained by those features. So that's crazy for 2 reasons. One is it really emphasizes how our physical and natural environments totally determine and shape, not totally, but very much shape our health and our circumstances and are a big part of what public health needs to be and already is. But the second thing it shows, how much we can gain from satellite images. Because not everywhere in Canada or around the world are we going to be able to do really rigorous epidemiologic studies to better understand the exact adult obesity rates or something else. We need to be thinking of these alternative data sources. In this case, it's totally free and available for everyone to access those satellite images. Let's use another example. So instead of satellites, let's go to food inspections, something that comes up in public health quite a bit. Now, if I was leading a public health unit responsible, and a part of that job was to investigate foodborne illness, I would hope that I have something better than just random audits of different restaurants, for example. Now, that is one approach. Another approach could be based on telephone calls, complaints, a complaints-based model. In an era of limited resources, that might be what we have to do. But how much better would it be if we could have a system whereby we're actually getting data and being able to target our food inspections, or restaurant inspections, for example, on the basis of a lot more data than just the people who call in? Because I don't know about you, but I personally have never called in, even after I've definitely had food illness, food poisoning at a restaurant. And I'm sure most people don't either. But I have tweeted about it. And other people do too. In fact, so many other people do that in Las Vegas, they used this system. Basically, they were looking at various tweets, and because tweets are all geocoded, unless you tell them not to, they're geocoded. So what that means is a tweet goes out saying, oh, this was a great restaurant, or even just knowing, Twitter knows where you were at one point, if you allow it to do that. And basically what it does is it's collecting this data such that even if it's a couple days later, in this case, they collect data for 5 days, they are able to then go back in time and say, okay, that person got sick. Where were they over the last 2 days? And are able to isolate from there. And the really interesting thing is basically this is what Jon Snow did with the Broad Street pump, identifying cholera. Except he had to go around to the neighborhood in Soho in London to identify, okay, you are sick, you have cholera, what did you do, right? Contact tracing, or well, that's not contact tracing, that's environmental tracing. Looking at what are the common elements that they all share. And this does it automatically. And in fact, from this study, Las Vegas was able to identify 12 restaurants a day that it needed to look at and make corrective action. I guess there's a lot of restaurants in Las Vegas, but they got, based on this, 12 per day they were able to get. And it was based on aggregate citizen science as opposed to random audits or praying people call when they get sick. The third and last example I'll give is one related to using AI for HIV prevention. Now, one of the important interventions in HIV prevention area is thinking about how do we use either key opinion leaders or peer networks. How do we better use peer change agents in order to encourage safer practices? And so one thing that's often done, so for example, this study was in the context of a youth homeless shelter. And what was done initially in this context was that the people who work at the shelters were asked to identify who do they think are change agents, who could be, encouraged or work with as partners in order to encourage other youth in order to go through HIV testing, as well as encourage the use of condoms during sex. And so that's one approach, asking the employees who do they think would be a good change agent among the youth. The other approach, which was tried in this trial, was using AI to try to identify who would be the best change agent. Now, when you're using AI, you can incorporate a whole bunch of different sets of data, and they did. So it looked at Facebook and said, okay, how many friends do these people have? What are the sub-communities? They were able to integrate the feedback of the people working at the shelter. And after it was done and it was tested, what was really interesting is it could then go loop back and say, okay, how did it work? And based on how the perception of the workers at the youth shelter were able to provide, the algorithm was able to learn over time. So that over time, better and better, the shelter was able to identify who are the best change agents that will spread. And in fact, as you'll see in the statistics, some of the practices more than doubled when the AI-chosen change agent was used versus the traditionally identified one based on just the perceptions of the shelter workers. I've been talking in glowing terms about AI because I'm really trying to convey the depth of the opportunity that I think we have in public health to really demonstrate the value of what we do and really amplify our work. But in moving forward, we definitely need to move so with caution. And so the example that might be on your minds at this moment is that of the Google Flu Trends Tracker, which in 2013, it was quite a big issue given basically finding that we previously thought that we were able to predict the flu and the prevalence of the flu using Google search terms, right? So when people would say, if they're sick, people often put in their symptoms right into the Google. Probably a lot of us are guilty of doing that. And so based on that, and they were able to correlate those search terms with known CDC data, they created a model that they thought was actually better than the CDC data. And in 2013, they found that Google Flu Trends actually estimated flu prevalence at double the rate of what it actually was. It did not work. Big fail. And so this really highlights, we need to move forward with caution, but it highlights two additional things. One is that there's a challenge of big data hubris. in the sense that we need to, when we're developing these models and using these technologies, we need to be careful and we need to make sure that we're not overly confident in them. We need to validate, we need to confirm, we need to merge artificial intelligence with human intelligence, with people who know their context and know when things don't make sense. The other thing that we learned, though, is that AI is not meant to replace epidemiology, not meant to replace public health. It's meant to supplement. It's meant to be a help. And so what this showed is that imagine the CDC had stopped collecting flu data. Not only would we be poor in our data, not only would we be thinking there's a lot more flu than there was, but actually we wouldn't even know it because we stopped collecting the data through the known and tried and tested means. And so what that shows is that in the world of AI, the work that public health is doing to collect this data is actually more important than ever, because we need that data in order to both train artificial intelligence algorithms, but we also then need to have it and continue to have it in order to make sure that that it doesn't go awry. So in other words, I said at the beginning, your jobs will change in 20 years, but actually they're becoming more and more important, and parts of the work that we do in the public health community needs to stay the same, at the same time as we're changing it. The other thing I think that this shows, or that we need to be careful of as we go into this space, is we need to be aware of bias that can be baked into algorithms and actually encoded in our data. What I mean by that is that artificial intelligence algorithms are not normatively free. They carry with them the norms and biases that either the people who programmed them had, or that the data had on which those learned models were developed. And so I think one very high-profile example of this was when Amazon started using AI in order to screen through all the CVs and resumes it was receiving for jobs that it had posted. Amazon took the very wrong view that it was satisfied with its existing workforce and therefore wanted new people that looked like its existing workforce. Looked like being the key word because Amazon at the time had a big equity and diversity challenge. Lots of people of the same gender and the same race. And so if you learn what a company wants to get from new people based on who it already has, basically women and minorities were algorithmically disentitled from being considered. Now, Amazon realized this, took corrective action, actually has stopped using that approach, but it shows a lot of people didn't get jobs and a lot of people were systemically, algorithmically discriminated against by accident because these sort of things were not thought of. Entirely predictable, but were not thought of. It's not just the algorithms, though, that we have to be thinking about. It's actually also the data itself. And so one of the big, exciting potential applications of AI is when you think of electronic health records. So these are records that, we all have at the hospitals and doctors that we visited, and have a lot of information about us. But we also know that there's some systemic bias within the healthcare system. And so, for example, we know that Black Canadians, African Americans in the US, face systemic racism and discrimination in getting healthcare. And the stats in the US are particularly damning. But when you see and it's particularly for African American women who are systematically treated differently in the healthcare system. So if we are adopting algorithms that are based on US electronic health records, and imagine we picked that up and brought it here, where we are, we might not realize it, but we might have imported systemic discrimination into our models so that when symptoms come up, the model might not just be reacting to symptoms, but also the patient's underlying data, which usually we want, right, if that is good data. What we don't want is to accidentally copy and paste systemic discrimination. And that's a big risk of happening if we use these approaches without thinking about all the implications and without thinking of the equity consequences. If we don't, and the risk here is that we could be really enabling an inequity inferno, essentially. That would be a really bad thing, and part of this why I think we need to be there. Because framed a bit more positively, it really, to me, emphasizes the role for public health in all this. Before I was really emphasizing why this is an opportunity for us. Let me change that slightly, though. I don't think that AI is just an opportunity. I think it's a professional obligation that we have to engage with this field. Even maybe when you think of what's at stake, maybe even a moral obligation that we have as a community to engage, because we are the only health discipline that puts equity at the core of what we do. It's a central tenet. Now, others in the health system and in the broader society, I hope, think about equity, and some do a lot. But we put it at the core of what we do. I think most people in this room or listening online will agree with me that if we're not thinking of equity, we're probably not doing our jobs in public health. We in public health are thinking not just of the people who are in front of us, who come through our office door. We're thinking about all the people who we don't even see, sometimes even can't see. We need that thinking. We need that approach to permeate the development and application of artificial intelligence. Because if not, we're going to get more biased models. Because this is not on other people's minds in the way that it is on ours. We might eat, sleep, and drink these sorts of concerns. Others haven't even thought of it. And that's how you get something so simple as if you're basing a CV screener on the basis of who you already have, that you didn't think that there's gender and racial implications of that, if knowing what your baseline data is. That's kind of crazy. So we have actually a professional obligation, in my mind, to be involved in this space, because if we're not there, the AI of the future is not going to be pretty. Moving forward, one thing that I have the privilege of doing is, as the scientific director of the Canadian Institutes of Health Research's Institute of Population Public Health, we have an opportunity to try to think through what are the big things in each of the Institute's mandate areas that are really needing additional attention and going in the future. And so one of our 3 priority areas for funding research in this space is around equitable artificial intelligence. The key there being, it's about not just the development of new AI approaches, that's happening a lot elsewhere. We want to fund work that's focused on how we apply AI to public health issues, particularly public health equity issues, but also how do we make all of AI more broadly focused on equity, something we in public health care so much about, and have fantastic frameworks, tools, and methods to advance equity based on so many years of tradition in doing this work. And so our focus has really been on building capacity. We think that, and are very worried, that when we take a look at the public health landscape, we see amazing people who are inspiring on a daily basis, but not very many have skills in artificial intelligence or have the literacy in these concepts. Not as many as we'll need in the future and probably already need. And so we're focused on capacity in 2 senses. One is building capacity for people like you in this audience to be able to use these methods. From our sense, it's really about applying them in a research context, but increasingly others are trying to think about it in a practice context. But also building capacity to have conversations with the AI computer scientists who are developing new methods, and the capacity to talk about these equity issues as they apply to the development of algorithms. So it's capacity in those 2 senses. And we're already doing stuff, which has really been a lot of fun. So one thing that we're doing, just to give you a few examples, we've been working with the Public Health Agency, with Public Health Ontario, INSPQ in Quebec, and the BC CDC to fund health system impact fellows. So this is really about trying to fund postdocs who've just finished their PhDs, who are looking to be going into public health practice, to invest in them to be able to apply AI approaches to the range of public health issues that can be addressed. And what's been really fantastic is this is one of the projects where we've been able to work collectively. And we live in an interesting federation in this country, with provincial lines, but this is something that's clearly in common and where the public health agencies are taking great leadership, which is fantastic then to be part of that. Second, we've been funding some planning grants on equitable AI with partners such as the Wellcome Trust in the UK. We've been convening workshops to try to bring together those AI researchers with public health researchers. And just recently, we launched a call for proposals for anyone who wants to run a summer institute on equitable AI for public health, which will provide funding to actually support PhD and postdocs in the future to develop these skill sets for people who are coming from a public health background and might not have an AI for public health course at their School of Public Health at which they're currently studying. I'm going to end with this fact that we're all in it together. This isn't something that just at the Canadian Institutes of Health Research we can do, or just the provincial or federal public health agencies can do. This is something all of us need to be worrying about, because it's going to change the nature of all of our jobs, and it's both a risk if we allow ourselves to plow into that data iceberg, but also quite a nice opportunity for public health to demonstrate its value and its impact, and why we can increasingly be serving the needs of people in Canada and around the world. This, I think, is a huge opportunity for public health. The only question in my mind is whether we as a community take it on and take full advantage of it to advance the health of Canadians and people around the world. Thank you very much for this opportunity. Much appreciated.
So I do want to thank you, Professor Hoffman, for your insights and comments. I would say for me, what resonated at the beginning was the iceberg piece. I know I'm going to want a sword. So I will take whatever pieces I can from that to help us as we go forward. Thank you very much for your insightful thoughts. I am going to open the floor for a question and answer period, and I'm thinking the questions might be really interesting. And the same for answers. So if we can take one or two questions at the microphone. I see someone at microphone number 3.
Hi, it's Tasha Crocker from Public Health Ontario. I wanted to start by thanking you for all your initiative in this area, because you've really been spearheading movement in this direction, and I agree, I don't think we're ready for this. So all the work you've been doing has been great. We had a workshop that was funded by you on AI and infectious diseases. And so that I wanted to ask you about, so one of the big conclusions from that workshop was actually not about the methods, which everyone was really enthusiastic to use, but about how we move forward on creating access to the data. So your presentation was absolutely fantastic. I think there are lots of people who are ready to be at the forefront of this, but actually trying to get public health data accessible to researchers is not that easy because of all the restrictions that are around it. So I wondered if you could maybe just comment a little bit on that. It's hard because you can't really get funding. Like if you go to a funding agency and say, can you give me some money to create a data set? They kind of look at you and say, that's not research. And if you go to a public health organization and say, I want to make this data set available to researchers, they say, well, we don't do that. So it's kind of falling between the two. So could you comment on that piece? Thank you.
Natasha, it's great. First, thanks for your comments, and it's a great question. Data is the key behind all this, and in fact, if data in public health was so easy to access and so easy to make use of, then you'd probably find a lot more AI researchers finding us, instead of us having to kind of wave the flag, letting them know we're here and identifying the opportunity. It's a big challenge. That's part of it's something I think also we all need to be worrying about. It's so ironic though too, right? Because there's so much data everywhere. We're swimming in data, yet it's sometimes hard to find where the tap is. I mean, I think Public Health Ontario has some advantages in the sense that it sits on such rich data sets, and some of the amazing work that we've been seeing, I know where we just saw Laura Rosella on stage before, others at Public Health Ontario who've been able to make full use of that using AI approaches. It's very inspiring, and certainly the kinds of things we'd love to see more of in the future. It's part of a bigger challenge, though. We need the lawyers, but not in a problem way, in the solution-oriented way. That's what I teach my law students. But we also need people who are thinking of privacy issues. We need to think of new ethical frameworks that allow for this. It's such a great question, and I don't have the full answer, but we're working on it. And you're working on it, too, I know.
Yeah, I know.
Thank you. Microphone number 2.
Thank you so much for the presentation. Actually, I think this is a great tie to what you were just saying. My questions are around ethics, and so it's something I struggle with. I really am a big proponent of AI and using data for predictive models, but the problem I see is, and you alluded to this, we're creating data every day. And so when we start using this data in public health and in the public sector, we're also creating new data points that could be leveraged by corporations and others with potentially malicious intent. So I think my questions kind of center around consent. So can we use this data to influence people and feel okay about that in public health? As well, when we're collecting this information, how can we be mindful of how others might use it and how we might address that in the future?
Yeah. Thanks for your question. I think that AI and this whole big data era has really highlighted that some of our existing conceptions are not working for us anymore. So you mentioned consent. I mean, how many people have read one of those licensing agreements before you get an account on Facebook or software? Every time you download an app on your phone, I've never read one of them, and I'm a lawyer. So is that consent? That's not consent, right? Like that's not what when we talk about informed consent, that's sort of the opposite of informed consent. Yet we do it, right? How many people have a smartphone? Do you have a smart scale? Who has a Fitbit, right? I mean, we give so much of our data to companies in order to use, so the concern you're flagging is real. I think in public health, the really weird thing that I think we have to think about and tackle is that while Canadians, in particular, being in this country, are some of the most willing to give their own personal data to companies, apparently we freak out when we're giving it to governmental bodies, including public health. That dichotomy is noted and weird and a bit Canadian, apparently. That's the chasm between those two is not as present in other countries as it is in Canada. But that's a challenge for us because that actually is a barrier to public health using it, whereas others who, well, I mentioned some examples earlier, don't apparently face that same barrier. So I think your question, I think it really highlights that this type of work in AI is challenging those pretty fundamental concepts like privacy, like consent, which we need to rethink and develop as technology advances.
Thank you again.
And we'll take the last question at microphone 2.
Thanks a lot for the presentation. It's really exciting, and I'm really glad that you introduced the concept of health equity in your talk, and I'm hoping that you can expand on that a little bit in terms of the question of whose data we use, whose data matters. I think that when we talk about using Twitter or Facebook as means to inform our efforts around food safety or around vaccine distribution, there's a real question of whether we're going where the need is or where we have populations who have access to smartphones are using the platforms of the day and so forth. And I think that there's a real risk of, just as we have population and community health surveys that don't capture all of our communities, administrative health data that don't capture all health events, we have a lot of risk in this case of potentially leaving behind, whether that's 1% or 5% or 10% of the population to whom these technologies haven't penetrated, where many of these data are gathered. I can see in your talk that you're really interested in addressing this issue, and I'd love to hear more about it.
Yeah, well, thank you very much for the question, and it's one that is, I think, why we need to be there, because we care about these things. And unfortunately, that's not normal, in the sense that if you look at many other places, other fields, companies in different sectors, it's unfortunately not normal to be thinking of these things. We have to make it normal in public health. I think maybe another very quick anecdote, because we've run out of time, is that when I asked earlier how many people would prefer to go to their family doctor over going to Dr. Watson, right? IBM supercomputer. And about half of you put your hands up in the room. I would say, and I'm not the expert here, but based on things that I do know, I would say that if you are a white man, you might actually want to see Dr. Watson. Why do I say that? It's because almost all of science all of our clinical trials, a lot is very much done on, well, particularly men, and then in particular white men. And so what that means is, to the extent that we have our existing medical knowledge, it's actually biased to favor the needs of men. Because often, just as a way to simplify studies, women are excluded. And so the consequence of that in an AI world is that Dr. Watson, so the supercomputer that's building its models, or has its models, and when it's applying it, it's actually applying data and knowledge gathered from men to others. So if you are a white man and put up your hand about wanting to see your family doctor, you might have missed an opportunity to see Dr. Watson. But if you put up your hand because you're not a white man, I think actually that's what I would do if I wasn't a white man. I would want to see my family doctor because I'd be worried about bias that's baked into Dr. Watson. And so when you're flagging these issues about who, it's not only, but also who are we hearing from, but even more fundamentally, what we know is based on who we have studied in the past. And we need to think actually critically about our medical knowledge, because then what that means is we're basing models and predictions on that. And if it is biased, and it is biased, that's going to be problematic. So we have to change that as well. Thank you.
Again, I ask everyone to thank Professor Hoffman for just an amazing presentation. So. At this time, we're going to begin the poster presentations, and the posters are at the back of the room if you haven't noticed them yet. For those of us who walked through them yesterday, I knew I saw a theme, but I couldn't actually connect the theme. They are grouped by the Ontario Public Health Standards, so I should have seen that theme, so that they are laid out in the back there. We encourage you to take some time, browse the posters, listen to the presentations, talk to the presenters. We thank you, all of those presenters who dedicated their time and effort to create and submit such a wide range of topics for poster presentation. It is quite impressive. There is a listing of the posters within your program. So I will ask poster presenters to please proceed to your posters after these announcements. Lunch will be served at noon. And for students who are participating in the Sheila Basur Center conversation with public health leader Dr. Williams at 12:15, we ask that you get your food at the buffet and then make your way to room 204C is where you'll be going. If you want to get moving a bit before the afternoon sessions begin, we're offering a stretch exercise in the West Foyer at 12:40. So put on your comfort shoes. Maybe don't use your Fitbit though. After lunch, we're going to go directly into the concurrent sessions. So after lunch in this room, you'll go directly to the concurrent sessions, which are all on the second floor. You'll see volunteers with the purple topic shirts that are available throughout the venue to assist you in your directions. The afternoon refreshment break will be back here on this floor along with the exhibitors. We hope you enjoy the rest of your day and the rest of Topic 2019. Thank you very, very much.